This case is 45 years old female complaining of dull aching, persistent abdominal pains in the epigastric and left hypochondrial region, not responding to PPI and spasmolytics. Sonography was done and revealed the presence of left hypochondrial cyst, mostly in the pancreatic body and tail, and CT confirmed these findings. They describe the presence of a complex cyst in the pancreatic body encroaching on the tail region with enhancing cyst wall. So the patient was referred for further investigation by endoscopic ultrasound. Now we are starting examination of the pancreatic body and tail from the stomach in the fundus, just below the cardia. And here we notice this is a large cyst, and very important to notice here that there is a mural nodule. This may be a mural nodule, maybe a mucus plug, or maybe necrotic area. But here we notice a very important sign that there is a big vessel inside this nodule. So it is a very grave sign to find a viable vessel inside the mural nodule. And this vessel is arterial. So it is a big arterial vessel inside the mural nodule, which is a very grave sign for being a cystic pancreatic neoplasm, not an inflammatory pseudocyst. Yes, this is the splenic artery and splenic vein. This is the splenic vessels, and this is a big arteriole inside the mural nodule, and this is a large cyst. Now we will do FNA and US guided fine needle aspiration of the cyst to do cytopathological and chemical analysis of the fluid. The rules of cyst aspiration is first, try to do only one puncture. The second is try to aspirate as much as you can. Try to empty the cyst completely to decrease the risk of seeding. When you aspirate the cyst completely, then the pressure inside the cyst will be very low or minimal, so there's no pressure to push the fluid out of the cyst, so minimizing the risk of seeding, and of course prophylactic antibiotics before cyst aspiration. Some recommends avoid cyst puncture in the body and tail because the needle track will not remove during operation if the cyst proved malignant, and they allow aspiration from cysts in the head because this track will be removed during open operation. But others aspirate the cyst, recommending aspiration of the cyst. So here there is a debate, but in this case we decided to do cyst aspiration to be sure of being cystic pancreatic neoplasms, because the patient will undergo major surgery. Now we are using 19G needle because the fluid is turbid, so we use the widest FNA needle, and we are now aspirating the fluid, and we will try to aspirate as much as we can. After cyst aspiration, we should do the string sign or the stretch sign. Yes, here it is a positive stretch sign. Yes, positive stretch signs. More than 4 or 5 millimeter, it is positive. So it denotes mucus secretion or mucinous secretion, which is predictive of mucinous cystic neoplasm, and its accuracy is about 90%. The cyst fluid was sent for cytopathological and chemical analysis. Cytopathology revealed positive mucin stains by Alcian blue and the presence of cells containing mucin, and shows moderate dysplasia. So the cytopathology is suggestive of mucinous cystic neoplasm. Chemical analysis revealed markedly raised carcinoembryonic antigen, which is very specific for mucinous cystic neoplasm. It was about 4,000 nanogram per milliliter, while amylase was normal. It was about 25 unit per liter. So excluding the diagnosis, or nearly excluding the diagnosis of inflammatory pseudocyst, in which the cyst amylase usually very high. The CA 19-9 is 35,000 units per milliliter, but unfortunately this is not specific for mucinous cystic neoplasm. It is also raised in inflammatory pseudocysts. So the most important two markers in the cystic fluid, the first one is carcinoembryonic antigen, levels above 800 nanogram per milliliter is highly predictive of mucinous cystic neoplasm, and here in this case it was 4,000. And the second marker is amylase level, which is usually raised in inflammatory pseudocyst, but also raised in intraductal papillary mucinous neoplasm. Is not the case here because the pancreatic duct was not dilated, but more important is amylase level when it is very low or normal, so it points away the diagnosis of inflammatory pseudocyst. So this case is a classic mucinous cystic neoplasm, classic by EUS features of mural nodule with a viable arterial vessels inside, classic by giving string sign after aspirating the fluid, classic by the very high carcinoembryonic antigen and the very low amylase level. So the final diagnosis was cystic pancreatic neoplasm of the pancreatic body and tail, and of course the patient was sent for surgery for partial pancreatectomy.